I'm given a topic of a current limitation of PFA, and I understand that may not make me very popular among the industry if I'm to talk about this, but the truth needs to be told, right? So, with the time we have, it's very difficult to talk about the limitations. But with every energy source I look at these five factors, right? Safety, effectiveness, efficiency, reproducibility, and value. So I probably will only cover one in this time span. But let's talk about, what we've experienced with and what I think what the limitations are. So as far as safety, we know that every PFA is different, is very variable in terms of how they assess every component of PFA that comes together to make it work. So safety aspect is variable amongst every one of them. And the most attractive part about PFA compared to RF and cryo is, of course, fissure is lower, probably zero, we hope. Phrenic will be lower, never zero, we heard. Stroke hopefully is low, and PV stenosis without heat energy hopefully is very low. And we know from the clinical data that I will not belabor in that the real world for safety have very low events in some of these major concerns. But every destructive energy cannot be risk free, right? They're still destructive, but they're just in different ways. They're destructive. So you have too much of power, current density, is not titrated well, then you may have the bubbles, hemolysis, muscle stems. You don't titrate enough, you don't have good enough lesion. So it's really walking a tightrope. So with the experience with PFA, I think the table really needs to be expanded because the atypical complications are now popping up, right? Silent ischemic events, whether or not it's coronary spasm or endothelial injury is part of the issue. Hemolysis may be an issue. So we'll go through some of that. Now, earlier this year, Nemesis PFA was presented, and it presented some of the differences in PFA, and including cardiac troponin is very significant. Is that good or bad? Maybe we're finally producing good amount of lesion, right? And acute injury and ejection fractions and such. So these are all things I'll try to cover. Hemolysis, well, to be honest, I think it's controllable. We know hemolysis happens, is significantly more than RFPF, but is it significant enough to be worried? Every PFA system has different degree of hemolysis. The most experienced right now may be with Fairwave, so that's being most reported. And so, with our experience, even without significant hydration, we actually think they can get away with most of what we see as less than 100. And that probably covers most of the PFA we need to do in most of the ablation we do. So, but I think it's controllable. But if you go overboard, you will injure renal cells. But is it just the renal cells, right? The free hemosiderin that's released is the toxic amongst every other organ. So we have to be careful about the limitations. Coronary spasm. This worries me a little bit more because this is different. And can it be avoided? Sure. I will not go into detail of coronary spasms and whys and hows, except, of course, it can happen. It will happen probably near 100% of the time, just few percent leads to ST elevation. And in the studies now, I'm beginning to learn as well how much nitroglycerin is needed to try to prevent spasm. This is a lot of nitroglycerin. So, do we just go back to RF near the annulus? Are we truly having advantage of PFA in this? So, I'm personally debating about do I open another catheter every time I convert a fib to a flutter, right? And it's not just about instantaneous spasm. We know it happens in minutes, but now reports coming out that this may happen well after a few minutes. Is this something we need to worry about, right? There are other reports, in case reports I review about same day discharge and sudden death at home that may be attributed to this. So is that a concern, right? So these are the things I'm just raising questions. Is it just spasm or is it endothelial damage as well? Right, there's been reports as well about neointimal hyperplasia as well as neointimal changes, luminal changes that's evident after PFA. So these are all things that just raises questions. But beyond hemolysis, spasm, what I truly worry more about personally is my brain, right? Or the patient's brain. Does this matter? Does silent ischemic event matter? Does this microbubble matter? Everybody thinks it's not a big deal until somebody stepped on a landmine to say, oh, maybe it's microbubble, maybe it's coagulum, maybe it's temperature control, right? Whatever it is actually led to FDA recall. And so suddenly this is truly different than what we are used to compared to RF and cryo. So who's policing this and how do we optimize this? And does changing the irrigation rate suddenly change all the risk for stroke? Right. So that actually is problematic. Even the most popular kid on the block right now with Fairwave, if you look at the original Advent trial, the silent cerebral events is not minimal, right, compared to the thermal. So does this matter, right? If you look at across the different energy sources, sure, you're going to see RF and cryo. But just to be fair, I know this was published earlier, and I actually happened to review two of these for under cryo, that the silent ischemic event was very high. But in these two trials, the conclusion is one is if you combine RF and cryo, incidence of cerebral event goes up. The other is that, yeah, serial exchanges with for lasso and high density mapping is what's correlated with silent ischemic events. So, of course, sheath management, larger sheath, and everything else plays a role into this. But I can tell you that, with all the cerebral events that we see in the past, we certainly are trying to minimize it with the safest tool available. 20 plus years doing atrial fibrillation, I can tell you I never had a significant cerebral events. Last week, I had my first one, right, PFA. And so does it matter, right? So I think this is something that we have to probably keep industry honest in terms of, are we really looking at cerebral events? A lot of the significant data that's presented on lesion depth that was just presented with VT, we try some of those too. That's a lot of significant bubble we see doing this high power ablation too. And is it safe, right? Everybody loves a lesion. Everybody's not a 2 centimeter lesion, but is it safe? Are they safe in different ways? Right. This has been presented as well as if you go close to potentially hardware, uh, are you going to create issues? We already know that by going with the devices, ICDs, that can potentially destroy ICD circuit boards if you're too close to it. So one of the recommendation given to me by engineers that when you do PFA in patient with implantable devices, keep it 1 centimeter away from coils, leads, and everything. And certainly you need to reprogram the device to be protective. So that is my concern with safety. But I think, all in all, clearly this is, I do probably the most PFA in Arizona. I still love it. I love the posterior wall safety. So don't get me wrong, but I want to keep it as safe as possible in every manner. Effectiveness. We're all mesmerized by PFA. Acute lesion, acute disappearance of EGM is beautiful, right? All the different data, I don't want to go into detail, but the fact is that all the PFA trials so far are showing a 1 year success rate and acute lesion that looks like this, but when we go back looks like this, is concerning. Acute does not equal chronic. So I think the excitement from the 3 years ago when we started doing PFA, by the second year and third year, certainly has died off quite a bit. Some of the PFA are definitely a lot more reproducible. Some of them created more work, right? So now we have the whole lab that's so adept in doing atypical flutters, epicardial ablations, because that's what's left over from PFAs. So I think integration of PFA tracking current density is also critical. This is one we did 3 months ago, came back for atypical flutter. We map with high density. What you see is what you get. So it definitely is achievable. But I think with the workflow wise, you have to be able to track current density. So either a tool set has to be enough to say, okay, 2D dimensional, I'll take away with multiple ablation in one area so it's well covered, so that it's very predictable, or if you want to be very specific, it has to be tracked very carefully. That way we know where all the current densities are. And one difference in the energy source that I'll say on effectiveness is that for younger patients with AFib, with clear triggers like vagal, right? You drink ice cold water, AFib starts. PFA doesn't modify GPs. So those patients should be selected out more for RF and cryo. And that's what we've been doing so far still. So just to throw that out there. So PFA are actually coming out. So Boston is now having FARAPOINT. As you know, you're looking at it, it's different very much with the RF design. So the combined modality RF and PFA truly can be optimized, right? The circuit in principle is different. So there's so much on the market right now that's saying we're dual energy, but it's very hard to walk the fine balance between the two energy sources as well. So I asked my fellow to pull out IDE trials and say, just show me the success rate if we're going to look at success rate. And of course, if you still look at it, the newest kid on the block may not be the most popular right now, but it will get there. But some of the highest ones are even a size adjustable cryo balloon. People forgot it because it's less than a year on the market, it was replaced by PFA in most labs. But to get a reproducible, nice lesion is actually great. I think for the remainder of the 30 seconds, I'll just talk about efficiency. We were sold a bill of goods. I can go in there and be done and be very quick in the left atria. Of course I am. We are very good at doing that. But it's the 1 hour prep work of general anesthesia in our lab that doesn't actually cooperate very well with efficiency. So we don't get to do more cases, but it all depends on your workflow. I think you can actually do that very well. I think the reproducibilities are great. Yeah, my 4-month-old fellow actually doing first box lesion by himself. I didn't even scrub in because it's safe in the back wall. I'm not worried about him. So I think I'll just conclude saying that, yeah, my choice of energy source is still the wide spectrum. I use everything. I think it depends on the patient, depends on what their needs are, the advantage of each energy source. I think there are a lot of things to be learned, and I'll put a plug in for the special edition coming on Page Journal that will highlight every aspect of what I think need to be answered in the PFA. Actually, it's truly quite a bit of to digest. So I'll just say PFA as an energy source has been great. It's been safe, fast. I think will go a long way, and I think it's here to stay. But we just have to be aware that, of course, acute doesn't equal chronic. Safety profile is different. I think annulus is still very troublesome for me. I now go back to RF for a lot of it. And the lesion depth, I think, is challenging. And I think it can be solved with different designs. Sedation needs is all challenging in different countries, different labs. And I think avoiding PFA near the implantable device is a must. So in conclusion, are we there yet? So I'm still eagerly awaiting PFA 4.0. I had 3.0 here until I saw an ad that says they have put PFA 3.0. I looked at it. I'm not sure. I'm waiting for PFA 4.0. All right. Thank you.